Good morning, everyone. Welcome to Pediatric Grand Rounds. As always, thank you for joining us. If you are anywhere near the Tanglewood Complex, please do join us in person at the Mill Mountain Conference Room, and thank you for joining virtually. Today's speaker is Dr. Sam Hanke. I want to give a special thanks to Jill Lucas and the Safe Kids Coalition for fostering this introduction and bringing Dr. Hanke in to speak for Grand Rounds. Dr. Hanke is a pediatric cardiologist and an associate professor in clinical pediatrics at the Heart Institute at Cincinnati Children's Medical Center. He received his medical degree from the University of Louisville and completed his pediatric residency, chief residency, and cardiology fellowship at Cincinnati Children's. He currently provides medical care to fragile infants and children with congenital and acquired heart disease in both acute and outpatient settings. He's completed additional training in quality improvement science and serves as the Chief Patient Experience Officer at Cincinnati Children's Hospital. While not providing pediatric cardiac care, he serves as the president of Charlie's Kids Foundation, an organization he and his wife founded after the untimely death of their first son, Charlie, in 2010 to sudden infant death syndrome and an unsafe sleep environment. His organization has been committed to educating families around SIDS and safe sleep to help prevent other parents from suffering sudden and unthinkable loss of an infant. Please join me in welcoming Dr. Sam Hanke as our speaker.
Good morning, and thank you so much for that introduction. Can I get a quick yes? You can see the screen okay?
Yes.
All right, wonderful. It's great to be here with you guys. I love this time of year. I remember fondly as a intern coming into Cincinnati Children's, starting my residency, and I remember fondly as an intern coming out of intern year and the joy that was part of that. And I understand you guys are there at that celebration. Congrats to the interns that are wrapping up your first year, and the interns coming on. Welcome, and you've picked a wonderful career, and so congratulations for that. It's a pleasure to be with you guys. I've been at Cincinnati Children's, like you heard, for quite a while now, for 19 years, and I've learned a lot here, and having a chance to come and speak with y'all about infant safe sleep, something that's near and dear to my heart, is really important. I appreciate the invitation. So I have no financial disclosures. Today we'll be talking about the 2022 American Academy of Pediatric Safe Sleep Recommendations. We'll discuss the challenges and solutions to implementing these, and we'll introduce you to Charlie and to Charlie's kids. You might ask, why, as a cardiologist, are you talking about this? And while a very small fraction of sudden unexpected infant deaths is secondary to channelopathies, the vast majority of them have nothing to do with cardiology. So while I chose cardiology, infant safe sleep actually chose me. They chose me after our firstborn son, Charlie, who you see here, who was born 7 pounds, 11 ounces, 21 inches, the same weight and length that I was as a baby, healthy and perfect in every way. He was my wife, Maura, and I's firstborn son. And we were absolutely over the moon to bring him home. Our dog Lucy wasn't quite so sure about it, but we were thrilled about having the chance to welcome what was a long-term, a life goal, a life dream of ours, to have children. And we celebrated having him with us, reading him books, bath time. He really was healthy in every way. If you saw him in his newborn checkup, you would say he's healthy. And when we took him to his newborn checkups, he was healthy, and he was breastfeeding well. We were starting to get into the rhythm of what life is like with a newborn. Like all babies, one evening he was particularly fussy. And when he was just 3 weeks old, I offered my wife some help. I was a chief resident at the time. I said, let me hold him for a while and you can get some sleep. And I held him, was able to get him to go to sleep and calm down. And I sat down on the couch, put him on my chest, and put on ESPNs, watched some Sports Center, and I nodded off to sleep. I wasn't planning on going to sleep. In fact, most of the time, if you would ask me where does he sleep, it's in his crib or in the bassinet. But this time he was with me, and Charlie died. When I woke up, life changed forever. And it's with that reality that whatever you have planned in your life will change. Whatever I have planned in my life changed. And I shared Charlie's story with you today. I shared Charlie's stories with others across the country for the last 15 years because I know there's more to his life than the 3 short weeks that we had. And we know that well, we give a lot of anticipatory guidance as pediatricians. At the time, we weren't really talking about safe sleep. We weren't talking about, we were talking a little bit about back to sleep. Safe to sleep wasn't really there. And the risk of sharing the same sleep surface like we were doing wasn't really well talked about. And as the more I learned about what happened to me, the more I learned that I was not alone and that too many babies are dying, and we can and must prevent their deaths. And I think as pediatricians, we are the key to preventing their deaths. We are uniquely positioned as trusted people in the babies' lives and their families, and are able to help them with the realities of trying to do the right thing each and every sleep. And when I say too many babies, what this means is that every 2 hours in the United States, a baby dies very similar to the way that Charlie's died. And these are preventable. I really appreciate Jill and the connection with Safe Kids, because Safe Kids is recognizing that these are actually injuries. These are injuries associated with sleep. Babies are suffocating in their sleep. And unlike other injuries and causes of death, this is a chart from, it's over 10 years now, but it's not a whole lot different. If you look at the causes of death for children under 21 years of age, you can see sudden unexpected infant death is right up there with car accidents, suicides. Guns have increased since 2015. But when you look at the amount of press and attention and awareness that is happening across our country and across our communities, it pales in comparison. This blue bubble is the Google search article results if you search for these topics, and you can see how much bigger and how much greater they are for important issues like gun violence, suicide, and motor vehicle accidents, but pale in comparison when you talk about safe sleep, SIDS, and sudden unexpected infant death. So we as pediatricians have a responsibility and a need to bring more visibility and awareness, both face-to-face when you're working with families, but also advocating across your community, working with groups like Safe Kids and other injury prevention teams within your hospital and within your community. There's a little bit of an alphabet soup. It's kind of hard because most people think about SIDS. It's an abbreviation for one. People don't love abbreviations. People think that just, if you ask the people in the community, it's just something that kind of happens. We don't really know why. And in fact, that's the definition. And so I want to go through a little bit around what definitions are here. So you as pediatricians can be informed of some of the nuances of it. So when you're talking with families who have read and learned more, you can help clarify some of the facts that they are coming to you with. So SIDS actually falls under a broader umbrella that's called SUID, or SUID, which is sudden unexpected infant death. It's not unexplained. Sometimes people make the U unexplained. It's sudden unexpected infant death. And that's when a death of an infant occurs suddenly and unexpectedly, whose cause of death is not immediately obvious prior to investigation. So you take away some of the trauma, you take away some of the other hospital deaths, et cetera, that there are clear causes. And so those comprise what are SUIDs. And if you break that down, it's almost equally distributed across the 3 causes of sudden unexpected infant death, with SIDS being the slightly largest, or sudden infant death syndrome, unknown causes being the second, and then accidental suffocation and strangulation in bed, which is also abbreviated to ASSB. So SIDS is been around for a long time, and the definition of SIDS to be coded as a SIDS death is an unexpected death of an infant under 1 year of age. So everything I'm going to be talking about later about what's the recommendations, families might say, how long do I need to do this? They're technically for under 1 year of age because that's when sudden unexpected infant death and SIDS occur. When there's no cause of death determined after a thorough investigation. This includes death scene investigation, an autopsy, and the review of the baby's medical history. So things have to happen from a post-mortem review process in order for SIDS to be coded, and which is why that unknown reason is quite high. But even when those happen, if you look at those and compare them to other causes of infant mortality, SIDS alone is the third leading cause of infant mortality in the country. This is data from CDC from 2022 and 2023. Even when it only comprises only 41% of all SUID, it still comprises a very large percentage of reasons why babies are dying. Now, we spend so much time in our training, and you're spending so much time in your hospital, money in our hospital, trying to figure out how to reduce the mortality associated with congenital malformations, with prematurity and low birth weight. What we do in terms of spending time and money and training around SIDS and other sleep-related injuries and deaths, it pales in comparison. Now, ASSB is the second cause, and that stands for accidental suffocation and strangulation in bed. And so this is used when there's more clear connection with either suffocation by soft bedding, an overlay event, a wedging or entrapment, or a strangulation. And so this is when there's clear more conditions in the sleep environment that are more consistent with suffocation and strangulation in bed. And then finally, the unknown cause, which is unfortunately a large percentage of that pie chart you saw earlier, is a death that cannot be explained because a thorough investigation was either not conducted and the cause of death could not be determined. And so we're still sitting with a lot of uncertainty. So it's hard to prevent uncertainty. But we do know, and I'll show you in a little bit, that very few of these babies are being found with no unsafe sleep factors present. And why this is so important to talk about is that if you look at the trends over time, you might say, well, things are looking much better when it comes to SIDS. This is data that came from the CDC, the most updated data from 2022, going all the way back to 1990, which I think some of the interns might not have been alive back then. But back then, we were talking about, prior to that, we were saying the best place to put your baby to sleep is on their belly. And so the grandmas and great grandmas that you talk to say, that's not what I learned, because that's not what we were teaching them. The Back to Sleep campaign in the early 90s had a profound impact on decreasing the rates of SIDS and sudden unexpected infant death. 30 to 40% decrease, and you can see here clearly in that chart. Now, the challenge is that since 2000, that has kind of plateaued off. And you might be able to say, look, we're improving the rates of SIDS. We're doing a really great job, right? But if you bring in these other categories, that ASSB and the unknown categories, you can see that tells a little bit of a different story. Over time, the rates of unknown cause and ASSB, which is hardly being coded in the early 90s, has gone up significantly. So when you're putting it together and you're trying to describe how is the rate of sudden unexpected infant death looking over time, the story is very different. It's plateaued. It's plateaued since the turn of this millennium. And in fact, over the last several years, it's going the wrong direction. So we have work to do. You can see in red that's highlighting that we are increasing in our country the rates of SIDS and sudden unexpected infant death. And the message is not getting out. Our ability to help families deal with the challenges of this is not being met. And as pediatricians, we have a responsibility and an ability to help improve this. So that's great. This is what it looks like nationally. Well, how about the state of Virginia? Also on the CDC website, you can look at state variation. And the average in 2022 of deaths per 100,000 live births was 100.9. The state of Virginia was above the average with 105.5 of rate over SUID. So you can see there's a lot of variation across the country. The South is not as great as some of the other areas. And Virginia is above average, but not in a good way. And because you can't have a 0.9% of a human being, and because rates per 100,000 don't mean much, what this means is that in Virginia, every week, 2 babies are dying and 2 families are being struck with this grief that will never leave. And these deaths can be prevented. So that's why you're here. That's why I'm here, is to talk about how we can actually prevent them. And they can be prevented, and we know they can be prevented because from all the investigation and all the coding data, what we know is less than 1% of these deaths are occurring where there is no unsafe sleep factors clearly present. So if we're able to actually improve the incomplete information, I'm sure that 1% will go up a little bit, but the vast majority of these deaths have these babies being found in positions with items or locations that are not aligned with what the American Academy of Pediatric recommendations are. And as pediatricians, that's what we want to try to spread. So let's spend the rest of the time here this morning talking about what these recommendations are. And I like to talk a little bit more from a practical perspective than a scientific perspective. But we have to be anchored in the science. And the science has been pretty consistent, especially over the last 14 years. And the science is primarily coming from the American Academy of Pediatrics. Initially, it was the SIDS task force. And it still is, it's evolving a little bit. But what's happened is every 5 years, there's recommendations. And these recommendations take into account all the evidence that's occurring and all the research that's happening and what we're seeing from CDC and other areas. And those all go into what this report says. And there's a lot in here. And handing a family this report isn't really going to help them understand it. To be honest with you, handing a pediatrician this report who doesn't care about this isn't really going to help. So there's a list of things that you can have. And I encourage you guys to look through the 2022 report, or this is the 2016 report, because it's mostly the same. But ultimately what this distills down to for this audience here is, one, as healthcare providers, especially those in newborn nurseries and NICUs, those on the inpatient units. I saw that team pop up earlier here. We have a responsibility to endorse and model the SIDS risk reduction recommendations from birth. So it starts from what we show them in our hospitals and our health systems and what we tell them within our outpatient clinics. So while there's a long list of different A, B, and C level recommendations, what you can take home, especially when families are asking about specific circumstances, is that these guidelines are trying to increase arousability while decreasing asphyxiating environments. So if they're saying, is this weighted blanket okay? Well, I didn't see anything about the report about a weighted blanket or a weighted Merlin heavy suit or whatever, but I can imagine that might increase asphyxiating environments. So that's something that I would say we shouldn't necessarily be doing, and it's not necessarily going to help with arousability. So while this is what those recommendations are simply put, this is what it looks like. And we want to model and show and talk to families about a baby that's on their back and their own sleep surface and their own crib in this particular case, with no loose items around them, and sleeping soundly. We also know that that's the idealized environment. What we also realize is that there's so many different social circumstances, and it's important to have the baby with you, but not in the same sleep surface with you. So this was an ad campaign that came out probably about 10 years ago from Cradle Cincinnati here locally, that highlights, you can actually be able to bond and connect with your child close to your heart, far from harm. So while it's easy and simply put, it's actually very hard to follow. It's so hard to follow that when we look back in 2012 about do pediatricians and attending physicians actually practice what they preach, when it came to safe sleep, we didn't even follow it. And I'm sure if I polled the audience here with children, you would probably say, yeah, I didn't do it all the time either. While back to sleep was something that we reported pretty frequently, 91.4% of the time. Bed sharing, co-sleeping with infants is quite high. 57.1% reported sharing a sleep surface with their infant. So I share my story knowing that what I did wasn't that exceptional, even amongst my own peers. So many people sleep with their babies. Why Charlie death happened to me and to my wife, I will never know. But I consider myself unlucky that happened, and I want others to put themselves in that position where they're not going to be at risk. And so that's what we're trying to promote today. I also like to use analogies of like a car seat too. Or the seatbelt, for example. You put your seatbelt on every time, not because you're planning to get in an accident, but when you do get in an accident, you want to make sure that you're taking those right precautions. And when the environments are right, situations you want to make sure that you're using those safety practices. So we need to do better ourselves for us to be able to work through families with their challenges. We'd like to distill this down into the ABCs of safe sleep. You probably have seen these. Most families reports have seen these. Some families can report what they stand for as alone, back, and crib. And those that actually can say that, I don't really like the alone piece. I don't want my baby to be alone. How many people want to be alone, your baby to be alone? And of course, that doesn't mean lonely. It means that there's nothing else in the crib. And what we've started to evolve and trying to take the ABCs is to change it a little bit differently, to say on their back in a crib and pack and play with nothing but baby. Nothing but baby takes away the loneliness piece, and hopefully this will resonate a little bit more with your family. So use this language. You can ask them about the ABCs. You can ask them what their feelings about alone means, but you can also use this different language to help drive the simple part message. Despite us talking about what infant safe sleep is, we know that more families know the right thing to do. But as you've seen from those death rates, we know that the right thing is not being done. And that there's a lot of myths out there about why, what it means. And those myths, I think, are often driving families choosing to do the more unsafe thing. So let's talk through what some of these different myths are. The first, and one that we hear quite frequently, is that my baby will choke on their back. This myth is partially because of our old message, which is what we would tell them back in the 80s, is that the baby would choke if they're on their back. We know that that's not true. That the evidence has shown that there's no increased risk of choking or aspiration. Rachel Moon, if you're familiar with her, she's been the lead author of the task force for quite a while. She's used this diagram in her clinical practice quite a bit and loves to talk about the anterior-posterior relationship of the trachea and the esophagus. I don't think she uses the word anterior-posterior with her families, but she talks about the anterior-posterior relationship of the trachea and the esophagus and how gravity actually pulls down, feeds into the esophagus and makes it less likely to go into the trachea when they're in the supine position than when they're in the prone position. So this diagram is one that's widely available online that you guys can use as well and print out if you like, if this is a way to help to mitigate what this risk is. Now, I'm sure many of you are taking care of kids in the hospital right now, and you're like, but my babies are different. And we think that they're at a greater risk. So we need to have reflux precautions. Well, what are reflux precautions? Well, we like to elevate the head of the bed up, right? Because that's going to help decrease that. We know outside the immediate feeding period, that does actually nothing for decreasing the reflux episodes. This is a Cochrane review going back to 2009. It looked at different studies around infant reflux and particularly around the reflux index related to the infant positioning. And they found that compared to head of the bed elevation and supine, there was not a significant change in what those reflux indices are. But in fact, actually, it's prone and left lateral that's going to make you reflux less. So if you have a particular refluxing baby, it's not heading to bed elevation. It's going to be prone or left lateral. And we know that's not what we want to do because of the risks of asphyxiation too. So that's part of the evidence that's behind this. And there's a lot of old data and old knowledge around these reflux precautions that we want to push back on. This is one that we really commonly hear and see about, which is, well, there are safe ways to co-sleep. And that sleeping with my baby is something that is important to me, and we know that it's going to that it's helpful for me to be able to bond with my baby. The evidence has been very critical at looking at this because there is some controversy here, and it's repeatedly been able to state that no studies have shown that co-sleeping is protective against SIDS or suffocation. And there's no way to control the many risk factors associated with bed sharing. So as a result, that's why the American Academy of Pediatric guidelines have been consistent in saying that you cannot bed share or co-share with your baby. And especially driving home this risk and importance when the babies are younger, when the infant is less than 4 months of age, when there is tobacco exposure, smoke exposure, that has also been linked to decreasing arousal and alertness. We know that when the bed sharer is not a parent, that risk is also increased. And then also, especially the American bed that has a lot of soft bedding, pillows, quilts, and comforters will place babies even at increased risk. And then particularly related to my story, couch, armchairs, these big chairs as well are even at a higher risk. So we see co-sleeping look in a lot of different ways. These are beautiful diagrams. If you look at sleeping, if you Google sleeping babies, these are the types of pictures that are shown on Google. These are the types of things that are too often shown on ads. You can see a well-intended mom there putting pillows around to keep the baby from rolling into cracks and crevices, but increases the risk of suffocation into the pillows. You see families with multiple siblings in there, stuffed animals, blankets. These are very common, cute, beautiful pictures that are very harmful and very unsafe. And most of the deaths that are happening across our country are being found in environments similar to this. So this is an article that was put out about 8 years ago about how often you see this. Oh, how cute. They get all these likes of babies falling asleep on their dad's chest, etc. Obviously, this is particularly hard for me to see and watch. But we've normalized this behavior and this activity as something that's safe. And the reality is that co-sleeping is always dangerous. Some practical and real stories can sometimes help. So I pulled a few of these out. The stories that we've seen here in Cincinnati and across the country. It can look a lot of different ways. The mom was breastfeeding, the 10-week-old fell asleep in the adult bed with mom, and the baby died. Co-sleeping with the parents, mom woke up on top of baby, squeezed between both parents. On the adult bed, found between wall and bed, put against the wall so it wouldn't fall off the bed, and instead they got entrapped. And then finally, co-sleeping in the adult bed on top of a boppy pillow between parents, mom rolled over onto the baby. I can say particularly this last one in Cincinnati, we just had a press release about 3 weeks ago. We've seen 4 deaths in boppy pillows already this year alone. So this is something that is increasingly happening as these nursing pillows are being used for sleep and are harmful for our babies. So while there is a lot of cultural, emotional, and this intrinsic desire to put your baby with you, what we love to promote is instead of with you, choose next to you, where they can sleep closely and safely. And I think the benefits that of bonding, the benefits of helping to soothe the baby when it's trying to get to sleep can all be met with next to you instead of with you. And in fact, that's been borne out in the evidence. Consistently, the recommendations have shown that room sharing results in a significant decreased risk of SIDS by 50%. It allows the easy bringing of bed to comfort or feeding when the babies are fussy, and it can help promote breastfeeding while minimizing the co-sleeping risk. and can help with the bonding as well. And breastfeeding is a super important piece too, because we want to be able to promote breastfeeding as for all the benefits that it provides, but also because it does result in a decreased risk of SIDS. For babies who have had any breastfeeding history, there's 50% reduction. And that goes up with exclusivity. So when babies are exclusively breastfed, you see a big improvement as well. We don't really know exactly why yet. There's been a few proposed mechanisms about either easier arousable breastfeeding babies will often wake up more frequently than bottle-fed babies. And then, of course, there is some connection that we believe with infections, and that could be contributing to whether it's airway obstruction, mild airway obstructions, the respiratory infections, and the benefits of the antibodies that are transferred during breastfeeding. So with all that said, there's a lot of confusion in our community, though. A lot of our breastfeeding colleagues, as they're working to promote as much breastfeeding as possible, can share and promote a message that's going to be different than what the American Academy of Pediatrics and what the evidence has said is the safest way and the best way to put your baby to sleep. And so these show up in a lot of different ways. You show up as a pacifier, which is one of our recommendations. Pacifiers reduce the risk of SIDS. And organizations like Baby Friendly USA has said, don't use pacifiers. They have Safe Sleep 7. There's books out here that say Safe Infant Sleep, that's written by an anthropologist that believes that you can safely co-sleep with your baby. There's Academy of Breastfeeding Medicine. It talks about breastfeeding and bed sharing. They call it breast sleeping. And when you look at the evidence that is behind this, it is not an evidence-based recommendation, and it's not rooted in what the AAP's evidence, which is the same evidence, it's not rooted in that reality. And so as a result, you get New York Post and others saying, calm the F down, you won't smother your baby, when babies are dying every 2 hours because they're getting smothered. All right, it turns out it's not just families that have some myths. We also have some myths within ourselves, as providers. How many times have you heard this across the hospital? Well, our babies are monitored, so we don't necessarily need to follow these safe sleep guidelines. This is what it's looked like at Cincinnati Children's in the past. These are HIPAA compliant because you can't see the baby. But hopefully your cribs don't look like this anymore, but it was not uncommon for our cribs to look like this. Items in the crib, sleep sacks or other blankets being brought up over their face, head of the bed elevation, etc. And while deaths are happening at pediatric hospitals while babies are being hospitalized because of suffocation, and we want to try to prevent that, what I think is even more impactful is the role that modeling the right thing to do has on our patients, our families, and then particularly our staff, who are often of child-bearing ages as well. This is a great comment that came from a focus group that we did here in Cincinnati. I wanted to reach out to you about an issue that came up this weekend. Our friends just had a baby. The baby had a few issues that had him in the NICU for 2 weeks. Their point was that while at the hospital, the nurses had blankets, animals, and stuff all around him the whole time. They felt that at the hospital, he could have loose blankets, animals, and lay in a different position. Why can't they? It made me think, how many more parents are going home with this impression? This is the truth. And the truth is that while there's so many sources of information, we are still the trusted source of information, and parents pay attention to us. They pay attention to us as physicians, and they pay attention to our nursing colleagues as well. This is a study that was done over 2 decades ago that showed that for what is influencing sleep position for very low birth weight infants, the number one thing that followed non-prone sleepers were physician and other medical professionals, and following the nursery practice. So what we do matters. What we do helps to show families what is important when they take their baby home, and can help decrease the risk of these deaths occurring. Despite that, we don't do a great job sharing the right thing to do. So this is a study that was done that's looking at the percentage of mothers receiving no advice or inappropriate advice from doctors, maternity nurses, families, and the media, and particularly looking at whether there's no advice or advice not consistent with the AAP recommendations around sleep position and sleep location. And on the left, you can see there that a little bit less than 50% of families were receiving no advice. About 20% received no advice from doctors about sleep position, and another 25% received advice that was not consistent with AAP recommendations. So we are not spreading the evidence-based recommendations. When you look at sleep location, that gets even worse, and you can see over 50% are not sharing what the importance of sleep location is. This is talking about bed sharing and co-sleeping and room sharing. And another about 25-30% are giving advice that is not consistent with the AAP recommendation. So when you take that and then add that to what other family members are saying, and then what the media is exposing to, it's no wonder why we've not seen a cultural shift yet in how our babies are being put to sleep. And as a result, the number of deaths that are happening, the number of preventable deaths that are happening. So there are a lot of things that we can do. This, like I said, is hopefully a practical conversation and presentation here today. You can do some things as the trusted voice for these families. The first is to set expectations. The setting expectations in your hospitals. Hopefully you have clinical champions, both physician and nurses, and find them, especially nurses. We all know that when you want to get anything done, the nurses are the ones that do it and get it done for us. So getting nurse champions, I found particularly night shift nurse champions who sometimes aren't part of all the grind and the whirlwind of the day. This is a great project for our nurse leaders that are third shift and night nurses. Make sure that there's a clear safe sleep policy. There's a lot of examples out there about what safe sleep policies are. Setting expectations from the policy standpoint is what so many hospitals follow, as we need to ensure that we meet these regulatory and policy rules. Talk to families early about these expectations as they're coming into the hospital. Obviously, once you stabilize them from a medical standpoint and things have kind of calmed down, talk to them about what the policies say, how babies will be sleeping, because it might be different than what they are at home. And it's a good way if you can set that expectation earlier as opposed to the very end. There are a lot of evidence-based recommendations for in-hospital interventions here. There's safe sleep start algorithms for NICU babies that have criteria for their readiness from a medical perspective. There's some great interventions around staff education. They get to particularly nursing, PCA, and other unit staff. Interventions like a crib card, which will make it visible at the bedside about what that particular baby's sleep environment and safe sleep should be, and if they are ready for safe sleep. And then finally, providing practical patient education material. In addition to modeling it, giving them some material about what's the right thing to do at home is quite helpful. So let's talk a little bit about what those resources are. This is a space that in Charlie's Kids that we spend most of our time as nonprofits is trying to create content and material that is available to you as providers can help communicate with families. And we take an approach that we want to try to normalize infant sleep patterns. And this really dives into breaking through some of did your baby sleep through the night? No, it's 3 weeks old. The baby should not sleep through the night at 3 weeks. So why do we want to ask that? How many people have heard sleep like a baby? Boy, I slept like a baby. What does that actually mean? It doesn't mean you usually, like anyone that's had a baby knows that sleeping like a baby doesn't mean you slept for hours on end. It just means you sleep a lot, but you don't sleep long. And so trying to change what that is in our society, we want to try to quickly get babies to sleep with the way that we sleep, even though that's not normal. Talk to families about developing a safe sleep plan. We have plans for all sorts of different conditions, but if we're able to have a plan that will help them be prepared for when the realities of this come about, that's super helpful. And then finally, practical solutions about how to get the babies to sleep. What we know from different studies and different evidence and talking with families is that when the safe sleep guidelines are not followed most of the time, it's because they just wanted to sleep. that chart showed decrease or asphyxiating environments, increasing around or decreasing, increasing arousability, decreasing asphyxiating environment. Well, you don't want your baby to be increasingly arousable. You want them to sleep. So we have to balance that with practical evidence and practical solutions to help soothe babies, calm them to sleep, and also engage social support networks and around them to help combat. Because what we know from this cartoon, which is nicely said, is that I'm afraid what you have is known as children. It's exhausting, but it's not exhausting forever, and it's so worth it. And talking to them and normalizing where they're at in that phase of their life is super helpful. And as that, and say, we can get through this. You can get through this. We can do this together. And so some of the solutions for combating exhaustion, deeply rooted in empathy, as that 3-step talked about along the sides, but normalizing sleep duration and empathy, teach calming and soothing techniques, and provide alternatives to bed sharing, which has become a default to try to get babies to sleep. If you're not familiar with the 5 S's, this is one that I use in my practice quite a bit. And most families don't seem to know about it, and it gives them kind of some stepwise, real practical things that can help. The 5 S's is swaddling, side and stomach position, shushing, swinging, and sucking. Obviously, this isn't going to be when the baby's in the crib or in their own sleep surface, because you're not going to put them on their side of their stomach. But if you're able to do this and you rock side to side, shush, have them suck with a pacifier, it is a very effective way, especially for babies less than 2 months of age, to get them to go to sleep. My unit here in the cardiology unit they laugh at me all the time because I've taken to a growl instead of a shush. So I growl at babies and they always laugh at me, but it really works. And it mimics the kind of sloshing, swishing sound and vibrating sound that the baby was so used to during fetal development. And it really helps to soothe babies down. So I teach parents that. I don't just do it at the bedside when the babies are hospitalized, but I'll teach parents that when they're coming for new murmur evaluations, etc. And what I particularly like about the growl is I get to talk to the dad. So much of this is being put on the mom, and with the exception of a low growl, the moms can do everything. Dads can't do hardly anything when it comes to babies. Like moms are, so yeah, Dad, this is something mom can't do. Like, you can do this, you can help. And that's a great way, I think, that I've been able to pull dad into being part of the solution for following these safe sleep practices. So try the 5 S's. It's been around for quite a while. Harvey Karp's a pediatrician out in LA who's been talking about these for decades. It works quite well. Charlie's kids for over 13 years have been distributing this board book. Hopefully you've seen it. It's called Sleep Baby Safe and Snug. It's a book that we created that was anchored in the AAP recommendations that said, well, people aren't going to read these guidelines in detail. So let's think about how we can communicate this to families in a way that they do know. My wife was a kindergarten teacher, and she's like, books. Let's use children's books. And this book has been able to provide timely, repetitive, safe sleep messaging, and it's approachable. It's easy to use. Families don't throw the books away. They throw brochures and other materials away, but they don't throw books away. And it's very relatable. It targets all levels of education. It promotes bonding and literacy. And it's really been something I've been so proud about as Charlie's dad, is being able to see this book distributed across the country and world with over 5 million copies distributed. And we hear all the time about how this book has helped their child sleep, and sometimes even their favorite book when they become 3 and 4 years old and still read it. So hopefully you've seen this. If not, our organization exists to get this type of material and content out as cheaply as possible to all organizations. We also know that families or new parents spend a lot of time on their phone. And so meeting them where they're at when it comes to safe sleep education, whether it's an Instagram or TikTok or Snap or whatever, is important. And we created these safe sleep videos here. These are 15, 30-second short videos that are trying to meet them where they're at and the language that they like to consume health education or to consume education in general. And so maybe just play one of them. This is a quick one that's very tactical about, let's talk about safe sleep.
Let's talk about safe sleep. Babies should sleep on their back, in a crib or pack and play, with nothing but baby, every sleep. On their back, never on their tummy or yours. In a crib or pack and play, not in your bed, not on your chest, not on the couch. Nothing but baby. No blankets, bumpers, pillows, or stuffed animals. In PJs or a sleep sack to keep them comfy and cozy. We know safe sleep is hard, but your baby is worth it. Let's talk about.
So that video is very similar to the other one. Some of the other ones talk about engaging parents and engaging grandparents and others, but feel free to use those. They're all free. You can get them on YouTube, you can get them on our website. And you can share those with your parents. You can put them on your own phone, and families seem to really like them. So you don't necessarily have to have a book, but you can share those as well. And you can share those with your other content. Other things that you can do when I've had a chance to connect with other bereaved parents like myself, one consistent message that we hear is that they never thought this would happen to them. That they thought their baby was the exception to the rule. My baby can't sleep on their back. My baby can't sleep in their own crib. You hear that so often. And most of the time, nothing bad happens. But every 2 hours, something bad does happen. And we want to not give them a reason to be an exception, so they don't become a statistic. But you can't do that by telling. You have to do that by empathy and listening deeply to their challenges that they're experiencing and messaging directly with them through your trusted voice that you have about how they're putting a baby to sleep, and to do so in a non-judgmental way. And so I'm going to leave you with kind of a few starters that can help. Instead of saying something like, you do safe sleep, right? Start conversations with families, particularly in the first 1 to 2 well visits that you have with babies, because after that, the sleep is often established. So being a new parent can be exhausting. Would it be okay if I shared some recommendations for sleep? It's very different than I'm going to tell you about sleep. What are your plans for where baby will sleep? What does that area look like? It's a very great open-ended question, and also talks about the need for having a plan and gets them thinking about that, especially that's a great one for in the nursery. How are you planning to stay awake during overnight feeds? It's acknowledging that that's a challenge and helping them understand some solutioning and help them get to solutioning, and then you can talk about different solutions. This newborn period, while exciting, can be challenging and exhausting. Do you have anyone to help you, support you, or give you a break? This is encouraging them to think about who in their community, who in their house, who in their support system can give them a break when this exhaustion sets in. And then finally, when I was a new mom and dad, I remember thinking about how much I wanted to sleep and how much I wanted my baby to sleep. One way I had peace of mind, was able to sleep better, was understanding how your baby could be safest when she sleeps. Could I share some things I learned with you? This is such a powerful way of connecting with the families, to put yourself in a similar type of environment. It's not saying what I would do, but it's saying what I did when I was a parent. And families really connect with that. It really helps put you at a position of like, yeah, this person understands me because they were in a similar position as well as parents. So try a few of these when you're in the nursery, when you're having newborn visits, or even when you're seeing babies for ill visits. If you find that you have some extra time, try some of these open-ended questions, and hopefully they find great ways to connect. So with that, I want to thank you guys for your time today. Hopefully you found what we talked about to be practical, to be meaningful, and you're taking some things that you can go directly to your practice and connect with families in a deeper and more meaningful way. And this is my beautiful family with our health commissioner and vice mayor and Charlie's angel siblings. This is Owen and Annie when we were celebrating our 5 million book distribution at one of our local pediatric practices. So thank you guys. I think we have a few minutes for questions.
How do we ask a question? We just go. Hey there. I just have a quick question because it's hard to get in front of all of the new things that are being sold to help your baby sleep. Like Snuggle Me, you can buy it on Target, and it says in fine print for helping your baby when they're active. But, and the picture, you know, the head is cut off, so you don't know if they're awake or not. But families use those to actually put their babies to sleep. And the ones that I saw most recently is Sweet Dreams, antibacterial, something, Hug Me. So basically it's being promoted by String Bingo to put the baby to sleep. And you see those pictures where the baby's actually sleeping and they're like, look, you know, it wouldn't be sold if it wasn't safe. How do you kind of keep the family kind of, you know, not being defensive, but then be like, oh my gosh, how could there be another thing that's unsafe for a child that's out there?
Yeah, well, that's such a real truth and challenge. And I've been talking for over a decade about this, and what changes is what the product is, but the problem has not gone away. There's a belief in our society that it can't be sold to an infant unless it's been shown that it's safe. That's not true. And I think that's one of the messages that you can start with, is that there's products that are being taken off the market every single day because they've been shown to be harmful, because there is not a need to prove that it's safe. There's also desire that as parents that we believe that we need all this stuff. And I think if you guys are new parents, you remember, like, I don't know, I get that. And by the time they've gotten to you as pediatricians, they probably had most of that stuff purchased already. And so we're talking a lot with our OB colleagues as well to try to get to them before those things are even purchased. And so I often frame them like, why'd you buy that? You know, you don't like start that, but what are you like? How are you planning on using that? Oh, okay, that's helpful. We often believe, you know, we often believe that these things have been tested on children and that they're safe, and that's just not true. And what I know about that product, it's going to put your baby at risk for having a suffocation, and you really should consider not using that, or I really recommend not using it. That's the type of way I frame it. And I don't know if it works or not. There's some work that's happening at like the policy and advocacy level to try to make those standards a little bit harder. Like that happened with cribs a few years ago. But that's the approach I generally try with all of the variety of different products.
Yeah, because it's tough. Like some of these ones that are more, you know, I mean, they haven't been taken off the market. I mean, it says in fine print while your baby's active. Just like I'm a gastroenterologist here, and the one that we're fighting against are these rare earth magnets, and they're sold for adults as stress relievers. But grandparents, you know, on the YouTube, I mean, like, what child wouldn't want that? And we've had children lose yards and yards of bowel because, and the family feels like, ooh, I'm gonna sue. Well, you can't, because this wasn't, you know, so. But it's out there. I mean, it's really, I always try to do a PSA when I'm taking a coin out, but, you know, I'm like, is there something that we could have I mean, I know you were saying books are better than pamphlets, but something that the family can go home with, just kind of to say, hey, just watch out for these things. I don't know.
Yeah, it's a good idea. We've not talked about content like that, but I love that idea. I mean, and we have avoided the whack-a-mole of going after individual products, but collectively, I think we do have a big voice in pediatrics. So if you're someone that's involved in social, we've had some success in tagging different organizations and products, and whether it's around the actual product or around the marketing of a product, they do listen from time to time. So I don't want to make it seem like we can't do anything. That's something that can really work too. And so reaching out to them via social is something that can help. But by far and away, the most impactful thing is the one-on-one family conversation. But that's hard to do at scale. But there's a lot of y'all, so we can do it at scale that way.
And then, sorry, I'm monopolizing. One more question. The book that you have, is that something that, you know, at CCHMC you kind of give to families, or like as an institution like Carilion, is that something that we could kind of be part of, kind of the education for families, like something that, like a package for their newborn, just so, like preemptively? You probably already are doing that.
We've been trying for a couple of years. It's about finding funding and getting our, and unfortunately, Dr. Hanke, I thank you for mentioning like our OBs. In our healthcare system, our mother-baby unit is a total separate entity that does not fall under our pediatric units, so they don't, I was just getting a text from a friend that said there's nobody from our OB unit, our mother-baby unit on this, which is very disappointing for us because we, you know, those are our first line of babies that we're seeing, and so many of them in these unsafe sleep environments. I will say kudos to our NICU. They do an amazing, once our babies are out in an open crib, there is nothing but safe sleep almost 100% of the time. But yeah, so we've been trying to do that and trying to get Charlie's book in their hands.
What about, I mean, I'm just saying, because I'm trying to do like a poop study for blah, 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 something different. So we're working with OBs to try and kind of get interest in parents, I mean, mothers before they deliver. And we're going to do like a laminated thing on the wall. You know, is there something that we could do something that's educational that could just be as they're waiting to see their OB one more time, that it could kind of educate them about?
Yeah, definitely thinking about that. And we, as educators on Mother Baby, we go around and we actually have a piece of paper that has pictures of the snuggle-me's and the mamaroos and all of the swings and all of the things that we get through Consumer Product Safety Commission, and we show parents that. We're like, hey, do you by chance have one of these or one of these or one of these or one of these? And then we talk to them about the dangers. But we could definitely look into getting that through our PR.
The prenatal pediatric visit is something that's kind of gone by the wayside to some degree, and that's a perfect opportunity for this sort of anticipatory guidance, I think. That's something we can look at.
Yeah, and we did just get crib cards that were printed that we're going to put on our crib that talks about what safe sleep is and what it looks like. That we're going to be putting on all of our cribs and on our mother baby units, and Pediatrics is doing it as well.
And I think it's relevant what you said about elevating the head of the bed, because sometimes we do that in the hospital, and you know, in GI it's a hard time for me to undo that, to be like, no, really, you know, we don't need to be doing that when they go home.
Speaking of elevating the head of the bed, Dr. Hanke, one area that I was wondering about if there's any data and some guidance is the area of car seats. So, because kids do spend a lot of time, you see parents will put their kid in the carrier, they fall asleep in the carrier, they leave them in the carrier. What do we know about the safety there?
Yeah, it's a great question. The evidence around car seat safety is particularly worrisome when they are unstrapped. So in general, there's not been a lot of report deaths in car seats when the babies are actually in the car or when they are staying strapped in. It's when they fall asleep because you drive them around the block, get them to sleep, you bring them back and you put their car seat in the crib or wherever, and you're like, oh, I don't need to strap them in because we're not driving. That is where there's been a fair number of deaths that happening as babies kind of curl in and get asphyxiated in their car seat. It's the same story that I'll give for families around head of bed elevation as well, and our nurses. That the risk is when they slide down and get into an asphyxiating position around that. And so there's a great biomedical engineer who's getting more and more involved in this community that is doing some powerful studies about the respiratory dynamics associated with incline and with car seats. I don't have that yet summarized well enough, but she does some great exercises about hunch your shoulders over and try to breathe, and then pull your shoulders back and breathe. And you can, I mean, if you guys do that now, you can feel the difference in the ability to breathe with that. And those types of stories are really helpful to give to families to talk about how those risks are real.
Dr. Hanke, thank you for that presentation. I'm a pediatric pulmonologist, and I think about how little I have continued to counsel families in this, especially my special needs kids. And as a cardiologist, I'm sure you have children who have particular conditions or at risk for multiple medical potential events. One of my disappointments with the data is that we have children who we lose who have medical conditions, sometimes complicated and vulnerable conditions, but they die unexpectedly. and we hear about it, we say, hey, that shouldn't have happened. And it's sometimes tucked away as natural causes based on the child's underlying condition without any investigation or proof. Do you have that experience?
I do. Yeah, this is one that I personally feel a lot of connection with because, you know, I take care of single ventricles, kids that have very complex diseases, and it's not common, but it's also not entirely rare that they'll go home and die unexpectedly and suddenly. And there's a triple risk model of SIDS that says that SIDS occurs when there is a vulnerable infant and a critical developmental period exposed to exogenous factors. The critical developmental period is especially this 1 month to 6 month age. The vulnerable infant has often been described as the premature infant, but we know these other complex medical babies like cardiac babies, pulmonary babies, etc., will fall into that. Kids that are exposed to more and more hypoxia are going to fall into that too. So then the exposure to the exogenous factors, which are all the safe sleep recommendations that we were talking about, I think becomes even more and more amplified. And so I firmly believe that some of these deaths that have happened over my last 15 years here, taking care of babies and discharging them, have been part of that model that and the coroners and the medical examiners are very quickly to say it's because of their chronic disease. And they're like, that shouldn't have happened. Like it should not have been because of their chronic disease. That's really hard to sort out. But I do share your sentiment there.
I think if we don't have any other questions, thank you so much, Dr. Hanke.